Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
I'm Hillary Liss, and I have been part of Mountain West AETC HIV Echo for a while, but part of my other life is I am a provider at Madison Clinic. And I also had the privilege of starting a Jail-Madison clinic telehealth program with my counterpart at the King County Jail, Jennifer Jones-Vanderleest, who is with us today. And hopefully she will jump in, and definitely at the discussion part at the end, I know that she will have a lot to say. And she is just an incredible provider at the King County Jail, Jail Health Services. And this has really been our baby for the last 3 years. And Brian asked me to talk to you all about what we've been doing, because I think it is something that people might be able to do in their settings. Without further ado, everything I know about jail and prison, I learned from Dr. Lara Strick, who I know many of you have heard speak before, who is the head of infectious disease for Washington Department of Corrections. And I think whenever we're talking about jail and prison, it's important to know the difference. So there are significant differences. Jails are run by counties or towns, and prisons are state or federal. Jails are usually run by sheriff's departments or tribal, whereas the prisons are usually State Department of Corrections, Bureau of Prisons, or Homeland Security. And then people in jail can be both pre- and post-sentencing. Usually if they're post-sentencing, it's because they have a short sentence. Prisons are only once someone has been sentenced. And like I was saying, the term of incarceration is generally less than a year for jails and generally more than a year for prisons. Jennifer and I can tell you that right now with COVID, with many courts being backed up or not even open yet, that the stays in jail, we are seeing people that have been in jail for years. So this is not written in stone, and right now I would say that there are many people in jails who are there a lot longer than they used to be, but most people really are short stays. And jails can have people who have not yet been charged, those with misdemeanors and felonies, whereas in prisons people already have been convicted of felonies. And I think it's really important to think about the numbers of people in jails versus prisons. We know that America, among other issues, we have more people incarcerated than pretty much any other place in the world per capita. We have many more people at any single point in time in prisons. We have about 1.6 million people in prisons, and these are older statistics, but they probably haven't changed very much. Whereas only about half that number in jails. And on any given day, there's approximately twice as many individuals in prison than jail. Whereas if you look across time, because people are coming in and out of jails, there are many more people annually that are going through the jail system than the prison system and are coming out of prisons and jails. So 95% of the 10 million individuals that are released from the criminal justice system are from jails annually. So we recognized a need for better healthcare for people with HIV in our jail system. And we are very fortunate, I want to say. The King County Jail has one of the most robust jail health services. They provide an incredibly high level of care. They have an incredible public health policies and procedures in terms of very robust HIV and STD testing at booking. They have nurse intake for every patient at booking. So we are very privileged to have started with a very healthy jail health services at King County Jail. But nonetheless, there were some things that we saw some improvement for. One thing is that, just a good background statistic, is that about 1 in 7 people with HIV are thought to cycle through the correctional system annually in the United States. And this is an extremely vulnerable population. Often they are out of totally or intermittently in care. Sometimes they're people that haven't yet been diagnosed. Many of these people are not on ART, and that creates personal and public health issues. And recent information from 2020 at King County Jail showed that 37% of people, and this is all comers, not just people with HIV, but 37% of people at KCJ reported unstable housing or homelessness at booking, and 19% said they were street living. We have people with many coexisting conditions in our HIV population in jail, including substance use and mental health issues. And short stays in jail make in-person visits very challenging. There's a lot of coordination that has to go on to organize an in-person visit. And if someone's only going to be in jail for a week or shorter, they're not going to make it to Harborview, to Madison Clinic to be seen. And in-person visits also come with some challenges. If you have the luck of actually getting an appointment set up and the patient agrees to come, a lot of times patients won't agree to come. They have court that day. They have a meal that they're looking forward to. They have a job at jail that they don't want to lose. We have a patient who regularly refuses to come for any in-person care because he knows that he might change housing when he comes back, and he doesn't like change and refuses. So there's a lot of challenges with in-person visits. The jail, and again, we are in an incredibly robust system. Our jail is only allowed to transport, and this was before COVID, and Dr. Jennifer, you can certainly correct me now or at the end, was only allowed before COVID to bring 6 people a day for non-emergent clinic visits. Obviously, if there's a fire or people have heart attacks, they will get brought in. But in terms of scheduled clinic visits, 6 people from the jail, which I think Dr. Jennifer told me. I call her Dr. Jennifer because that's what we call each other on when we're having our visits. So that's why if I slip into that. I think Jennifer told me there's about 1,500 people per day in King County Jail, and only 6 of them can come in for in-person visits. And before COVID, there was not a telehealth program at the jail for really any specialty. Only, I think they did a little bit for psychiatry. So there's limitations on how many people can come. And you can imagine if someone gets booked into jail who just had surgery or has a broken limb, they are going to bump our patients who are coming in for reestablished HIV care. And there's incredible costs to transportation. It requires multiple custodial officers. It requires the vans. It's a very big deal in terms of cost. And then there's significant stigma and confidentiality issues for our patients. They're coming to a public facility in red uniforms, often shackled, and it also is outing them to the officers, this person has HIV. So all of these were major problems, and in terms of specific issues with Madison and King County Jail, in 2017, King County Jail submitted 184 referrals to the Madison Clinic. Only 62 visits were completed, and I'm sorry I don't have the exact specifics, but I think some of those were actually to the infectious disease clinic. I suspect that number is actually a lot fewer people with HIV were being seen for HIV care. And there was an average 6-week wait to be seen. And out of 31 specialties at Harborview, Madison Clinic had the highest volumes of patient transports from King County Jail for non-procedure-based care. So clearly, there was a need. And just to give some more perspective, last year, the median length of stay was 3 days, and the mean length of stay was 30.5 days. And I think Jennifer and I would argue that might be longer. Those numbers might be bigger than they were in 2017 because of COVID and the issues I brought up. So as such, we embarked on a collaborative telehealth program. And I like to say before telehealth was cool, our first patient was seen in January 2019, a good year and a half before telehealth had really taken over our lives. So just to tell you a little bit, I'm not going to bore you with the details of our planning meetings, but we did have some planning meetings. And then really the anatomy of a jail telehealth visit is that a jail staff member emails a list of incarcerated people with HIV to the Madison provider and to the jail health provider. I review that list, and we will talk about what is required if anyone ever wanted to do something like this, and we would always be happy to help with that. is that I review the list, I update a central list for myself, and then I make recommendations on who we should see the following week in collaboration with my jail counterpart, Dr. Jones-Vanderleest. We have 2 hours set aside every Tuesday to see the patients, and then for patients we don't see, we review the list pretty much every week to make sure there weren't labs that rolled in or follow-up that we needed to do. And then a provider from both sites gets on a HIPAA-protected Zoom, and we set the session agenda at the beginning. And then a custody officer does bring the patient to the Jail-Health clinic. But again, now they're not leaving the facility. The custodial officer does not need to know why the patient is coming. They just are told, please bring this patient to clinic. Could be for any service. They have no idea. And again, Jennifer, at the end, correct me if I'm wrong. I'm really trying to be very specific and nitty-gritty here just to give people an idea of the personnel that are involved. The nurse takes the vitals, and then the provider at King County Jail, which is mostly Jennifer, brings the patient to the clinic room. We have learned so much. We always talk about this as a very bi-directional learning situation. What we have learned, one of our lessons learned, is that it's really good to tell the patient as they're walking in or right before they walk in that I'm going to be on the computer. A lot of our patients have some paranoia, a lot of medical mistrust, have been treated very poorly by the medical system in and out of jail. And we have had patients who it kind of freaks them out when they come in and they see that I'm on the computer and they didn't know why they were coming in and that was going to be the case. So we try and give them an idea of what's about to happen, and then we explain to them this relationship and this partnership. And then we have a very collaborative visit. Dr. Jennifer knows things about jail that I will probably never know about jail. She has been working in the system for so long, and she is so knowledgeable. And so, I will try to defer to her about things that I know. When a patient says, I want an extra snack, I don't always know what the rules are. Things like that. Or if we're talking about things with formulary, we are so privileged that our jail actually has a more wide formulary than our state Medicare program, but that's another story. So we have a visit. It's usually primarily a clinician at both the jail and at Madison Clinic, but we also often bring in the social worker or case manager from Madison Clinic. Occasionally we bring in the release planner from the jail. Occasionally, we have a patient who's been completely disengaged from care for a very long time, and we really want to engage them in our low-barrier clinic, the MAX clinic, which I think most of you have heard a lot about. And so we'll have a representative from MAX join us. Often the patients are just so relieved to see their case manager, who they know very well, because they don't really know Dr. Jennifer or me. The Madison provider documents and bills in the electronic health record, and then the jail provider also writes a brief note, although I joke she writes probably a better note than I write. And then it is up to the jail health services provider to execute the care plan and follow-up that we outlined during our visit. And then, an important thing that we don't just talk about the straight medical issues for the patient, we really try and identify release planning needs. So one thing that is this varies in different states, and I think even more locally and regionally than that, is that in most places when you are incarcerated, your insurance is discontinued. So people need their insurance set back up when they're leaving, and sometimes release planners can help get that coordinated before the patient leaves. Patients need a bridge supply of ART. If they're going to leave on a weekend, they may not be able to get to the clinic. So if they leave without their ART, they will not have medications. And we know that that is obviously a problem for all kinds of reasons. So we provide 7 days of ART at release. We put that in the patient's property. We really try to link patients to care. We have many people who have a regular provider. We have many people who don't. And we have many people who have been engaged in a certain system, but that really hasn't served them the way that they need to be served. And so we try and really identify what would be the best system for them and the best place for them when they leave. The jail is also able to provide some transportation assistance. A lot of people get put in a cab and the cab is paid for and it takes them right up to the MAX clinic, for example. We work on housing. substance use and mental health care, and then understanding ongoing legal issues, because those can have major implications for ongoing care when someone is released from the jail facility. They might be having electronic home detention. That will affect how we make appointments and how we can interface with that patient. Some patients will have very strict community custody or parole requirements that can really interfere with how they're going to get their care, or impact, I shouldn't say interfere, but impact how they get their care. One solution we've come up with is we also complement our jail health visits with a weekly multidisciplinary video conference that has me as a medical provider, we have public health representatives, we have representatives from the Max Clinic, we have a social worker or release planner from the jail, and then we have community-based organization representatives like from Bailey Boucher to assist with transitions, whether it's to the community or to prison. And we have representatives from DOC, I should have included on there, and to work on adherence, outreach, and linkage, engagement, and retention and care. So we have had what we consider a number of success stories, and we hope one day soon to actually get this in writing and really document what we have accomplished. But over the 3 years this program has been in place, and this is actually from 6 months ago, so we need to update this, but we have discussed and or seen approximately 255 unduplicated patients with HIV, many of them incarcerated on multiple occasions. And the average weekly census of people with HIV incarcerated has been 15 to 20. So, and we are touching them in some way, whether it is reviewing and deciding what labs they need, or seeing them, we have interfaced with them in some way. We have identified multiple new diagnoses of HIV, and that's really not a result of our jail telehealth program, certainly not directly. The jail has a wonderful opt-out screening program at booking. Are they pushing it more now that they know that patients can get excellent and rapid HIV care? I would only be speculating, but we have identified multiple new diagnoses of HIV at booking, or even later in hospital and jail stays when someone asks for STD screening and the jail health provider has said, how about we also do HIV testing? And these patients, for the most part, have started ART within days or weeks of diagnosis. We had a patient recently, we started, I think, within 2 days, maybe the day after the HIV test came back. The patient learned of their diagnosis and started on ART that day in jail. We've identified an HIV in a pregnant person and linked them to care. Sadly, they did not follow up, but we did get them on medicines and get them suppressed. But unfortunately, when they were released, they did not engage. We have improved communication with prison systems when patients transfer, and other jail systems. We have some patients who are sent out of state because they have a warrant out of state, and we have coordinated care with out-of-state facilities. And we've really been able, I sort of mentioned this before, to triage the level of care needed after release. We've linked people to Madison, Mod, Max, or another clinic, depending on their need or preference. We've had people that were assigned to Madison Clinic, but we really realized they need Max. And so we are able to connect them with Max while they are incarcerated and then after incarceration. And we had started this program, and this is really a success story. I was reviewing the slides from our early planning meetings, and we had said we are just going to see people who have an established relationship with Madison. And we blew that out of the window pretty early in that we just said we're going to see every single person with HIV, regardless of where they previously received care. And often they go back to wherever they previously received care. We don't care. We just want to make sure that they get the care they need while they're incarcerated and that they get linked back to care when they get out. And then when we started, King County Jail has 2 facilities. They have the King County Jail, I guess technically they may even have more facilities, but in terms of adult jail systems, there is one in downtown Seattle, just down the hill from Harborview, called King County Correctional Facility. And then there is one in Kent called Mailing Regional Justice Center. And at the beginning, we could only do this at one site, but we have managed to expand. So we now do every other week at the 2 different facilities. And then one thing that's really important is that, we know that there is a crisis in terms of HIV workforce. And this has really become a way to expand the workforce with HIV. We mostly have been working, Dr. Jennifer and I, but there are weeks that we bring in other people, and we have really had a mentorship relationship, again, bidirectionally. I have learned so much from Jennifer, and she was already highly, highly knowledgeable about STDs and HIV, but through this process, she became a HIVM specialist certified, so that was really exciting. I love this program so much, I forgot to put in a challenges slide. So this morning I just threw in a quick ongoing challenges. And Jennifer, I know you can probably add to this, but we still have people of very short stays. So, we don't get a list every day. There's not the capability for us to review the list every day. So we review the list on Friday. And if someone came in on Tuesday and left on Thursday, we won't know that they were incarcerated. So we still miss some people because of short stays. We still have patients refuse to see us. Even though they're coming, a floor or two or less, they still will sometimes refuse to see us for all kinds of reasons that I mentioned before. And then language barriers, we have not, interestingly, seen that many people where they're not able to communicate in English. But when we do have patients, if we don't have an in-person interpreter, it just does make it more complicated. And so I think we can still work on how we're going to best communicate with our non-English speaking patients. But interestingly, it has not been much of an issue to this point. So what would be needed to set up a similar program in your setting? It's important to have a relationship with a jail. And so if you have a relationship already, or if you know there's a jail in your region that you think that the patients could get better care for HIV, try to build a relationship. It's important to have a clinician champion at both sites. It does not have to be an MD, PA, nurse practitioner. Really at either site, but definitely not at jail. It really helps in a lot of ways for executing the plans, but I do think having a clinician champion at both sites is important. It's important to have administration support on both sides. It is really important to have someone who can generate this list I've talked about. There needs to be some system in place at the jail facility to identify incarcerated people with HIV. We know for sure that relying on what patients tell the nurses at booking would not be a reliable system. We have many people who, in the public setting of booking or for other reasons, do not disclose their status at booking. So relying on patient self-disclosure would not be very accurate. It's better than nothing, but it's not enough. You need to have pharmacy and lab access for this system to work, and I mean at the jail. You need really the most basic telehealth technology, and I think because of COVID, we all really have that. And then there needs to be some protected FTE for providers at both sites. And then there needs to be a plan in place if in-person care is required. So what are our future directions? We would like to involve more providers at both of our current sites. We would be happy to expand to other jails, both regionally and also mentoring people elsewhere. And then we do want to do more quantitative and qualitative evaluation of our program outcomes. And there's a number of people that Jennifer and I could not do this without, including really the people who came up with this idea, which was Shrisha, who you know very well, Shrisha Danareddy, who's the medical director of Madison Clinic, Ben Sanders, who's the medical director at Jail-Health Services, and John Scott, who's head of UW Telehealth, who you know him as well, and then a number of other people. So that is that.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.